Hello everyone, my name is Stacy and I will be doing my case study analysis part 3 on Ben. Personal history about Ben. He is a 20-year-old male with a history of drug abuse, which includes methamphetamine and IV drug use. He is currently unemployed and he has been for a little bit over a year, but before that he worked as a cashier shortly after graduating from high school. And he lives with his father in a one-story home, and his father will be his primary caregiver. Prior and current medical history include a middle cerebral artery aneurysm, also known as a stroke. Because of that, he is experiencing some right upper extremity weakness. Also included in that is his right lower extremity weakness. He is experiencing some cognitive delays, and he also has some expressive aphasia. Right now, he currently has some sternal precautions that are in place, which means that he's not able to lift, pull, or push anything more than 5 to 10 pounds. Also included with his precautions is he does begin to become dizzy after standing or being seated upright for a long period of time. This is usually due to an injury and being in bed for a long period, which leads to orthostatic hypotension, which is a pooling of blood to your abdomen and lower extremities, which causes low blood pressure. We'll be focusing on two of Ben's abnormal movements. The first one is an instability in his trunk, which causes a sideways lean toward his unaffected side, which is his left side. As you can see in this video, he is currently leaning over to that left side. And then he also has a flaccid right upper extremity, which is due to non-use because of his hemiparesis. And you can kind of see that in his video. Again, he has that side lean towards his left side and his flaccid right upper extremity. The first preparatory activity that we will be doing with Ben is passive range of motion. The reason why I chose passive range of motion is because of his loss of motor functioning in the right upper extremity. You can also do this with his right lower extremity, and because you'll be doing both, it is probably better to conduct them in bed if you are also doing his lower extremity for movement. The reason why we're doing this is because we're trying to maintain joint mobility and prevent any further capsular adhesion. Also, the client doesn't have to perform any active movement because you are the one that is putting them through all of those range of motions, and this is because of an inability to perform them independently. You'll also want to conduct caregiver training before discharge and allow use of that non-affected upper limb to move that affected right upper extremity through passive range of motion. The first intervention approach that we will be doing with Ben is sitting and standing dynamic balance. Now, obviously this video isn't of Ben, but it is of another client doing standing dynamic balance. But what is good is you're able to still conduct this type of activity in a seated position as well. So to preserve energy, we can also leave him in bed or in an armless chair. You will want to have his feet flat on the floor and have him in an anterior pelvic tilt with his head over his shoulders and his shoulders over his hips. Then we will add weight bearing to his affected upper limb, which is his right side, to advance rehabilitation of that arm. Short-term goal is that the client will complete 5 reaching tasks sitting within 30-minute sessions with 2 breaks to improve dynamic sitting balance twice a week for 4 weeks. Long-term goal is the client will complete a 30-minute reaching task that includes a couple of different ones in standing with height bearing as tolerated on the right upper extremity with 2 breaks to increase stability through the affected limb twice a week for 8 weeks. To modify this one, you will have him just do a couple of different ones, do left to right just to do some weight shifting through the hips, just making sure that he's crossing midline during those reaching activities is best for him. The second preparatory activity that we will be doing with Ben is transcutaneous electrical nerve stimulation, also known as TENS. Electrical stimulation is used to reduce acute and chronic pain, and pain is a very big barrier, especially for Ben, for his rehabilitation. He does have expressive aphasia, so he's not able to tell us exactly what hurts or at how much pain he's having. Instead, he's saying ow. So when you verbally hear that, you will want to stop any TENS stimulation that you might be doing. The reason why we are doing TENS is because we're attempting to stay away from any pain medications because of his prior history of drug abuse. Also, the TENS unit is portable. He's able to take that anywhere with him, and it is very inexpensive, so he's able to have one at home. We'll want to show how to use the TENS unit to the caregiver as well as the client before discharge. The second intervention that we will be doing with Ben is mirror therapy. Mirror therapy is recommended to be conducted with other rehabilitative therapies and used as a priming technique to influence the excitation of corticospinal neurons and improve the functioning of the affected limb, according to Bondoc 2018. In this task, the client will be performing about 5 different motions. He will do finger extension and flexion, thumb opposition, wrist flexion and extension, along with circumduction of the wrist. To grade this task up, he will begin moving proximally up the limb. So instead of just having him do wrist down, we will have him also do supination and pronation of the forearm, elbow flexion, and elbow extension. The short-term goal for Ben is that he will complete hand motions in a mirror with the affected limb hidden for about 30 minutes twice a week for 4 weeks to increase neural connections. Long-term goal is that the client will initiate movement independently to improve motor functioning of his right upper extremity and performing an ADL of his choice with moderate assistance within 8 weeks. To modify this task, you are also able to have a long mirror in between his lower limbs to also start doing that with lower limb movement. And if he's having trouble with this task because he does have some vision impairment on his left side, you can also patch that side to improve the visual imagery within that mirror therapy. Muscles that are involved within both tasks will be his shoulder muscle groups, also within the upper arm, the forearm, wrist, fingers, and trunk muscles. Within the shoulder, we have the infraspinatus, supraspinatus, teres minor, and subscapularis, anterior deltoid, middle deltoid, and pectoralis major. We also have the biceps brachii, brachioradialis, brachialis, and triceps within his upper arm. In his forearm, we have the supinator, pronator, forearm flexor muscles, and the forearm extensor muscles. In the wrist, we have the flexor carpi radialis, flexor carpi ulnaris, extensor carpi radialis, and extensor carpi ulnaris that are also found in the forearm. For finger muscles, we have the flexor pollicis longus, flexor pollicis brevis, abductor digiti minimi, flexor digiti minimi brevis, opponens digiti minimi. And then in the trunk, we have the external and internal obliques, rectus abdominis, and lumbar multifidus. Intervention approaches will also be volitional, as he will be conducting the tasks on his own because we are trying to initiate that motor control in his affected limb. First intervention approach, Ben does have that flaccid right upper extremity that does cause some limitations within the task, but using that weight-bearing activity is one way to modify it. And in the second intervention approach, his flaccid right upper extremity does not cause any concern for the task because it is hidden anyway, and we're just trying to make the connections from his brain down to his spine to produce the movements. Speed and amplitude are not important to either task, but we are worried about how much time he is taking on them because we don't want him to rush through them. We want him to take his time and really think about the movements that he is performing to really make those neural connections again. And these are my references. Thank you for watching.